All right. I'm excited to present my case, of course, as somebody who specializes in complex GI issues. This person is no exception to that, this patient. And I've been really grateful to work with her for the last 6+ months, probably 6, 7 months. But she's one of my favorite cases because she really does all of the 5 M's. So I will be kind of presenting her case as well as just our general thought processes when we're working with GI patients, how we assess and prioritize and understand what our patients' needs are. I'm looking forward to presenting about this patient. We'll call her C. But C is a 58-year-old female. She's been plant-based for about 7-8 years. And her background is very much of one you would see with a typical IBS patient, where we know it's not just always the one thing. Sometimes it is with IBS patients, right? Sometimes they just got food poisoning and that wrecked their gut. Or, I had a patient the other day who just did a parasite cleanse because she thought she needed to. Her friends were doing them and she thought that's what would help her the most. And since then, her gut hasn't been the same. But with a lot of GI patients, complex GI patients and complex IBS patients, you're seeing that there's a lot of involvement. A lot happened to bring them here to these debilitating symptoms that they often come to us with. And this patient is definitely no exception to that. She was born in the 60s, vaginal delivery, formula fed. She did from the get-go. Her parents would say that she was a fussy, difficult baby, which now we know means she was colicky. And so much more data now is corroborating the fact that colic is GI distress. So she seems like from day one, she had some GI distress. She did share her mother also had GI issues predating her and during the pregnancy. She said she had a pretty traumatic childhood. She lived in a very chaotic household. Her parents had very chaotic relationship. She had several siblings. She had 7 siblings. They were raised on a standard American diet, and she almost feels like her mother over-medicated her. She said she was frequently given antibiotics, medication. She feels like she had surgeries that weren't 100% necessary, but she just really feels like she got it all. She got all the medical treatments. She developed childhood asthma in her early teens. She had various spinal surgeries. She, at a very young age, 15 years old, began having disordered eating. So she would use diet pills. She went through a period of anorexia, yo-yo dieting, body dysmorphia. She feels like at home she never really had any normal meals, and no one was really supervising what she was eating. And the meals that were provided for her, if they were by a guardian, were never really balanced, or, they didn't sit down for family meals. So she feels like just nutritionally from the very beginning, there was disorder to it all from what she observed and what she was practicing herself. Her surgeries continued. So at 19, she had a tonsillectomy, and she said she was beginning to have rheumatic heart fever before she had the surgery. So she was given antibiotics during the tonsillectomy. She was given antibiotics to treat the rheumatic fever and given antibiotics after. She, 1 year later, had an appendectomy due to an infection. She said when they got in there, they said it wasn't very inflamed, but still gave her the surgical and post-op antibiotics. She had a couple quiet, dormant years, got married in that time, and then had her first pregnancy in the mid-90s. It was a C-section. She remembers after the C-section having significant bloat and trapped gas, which often is the case, especially with abdominal surgeries. They do inflate the abdomen and the peritoneal cavity in order to perform the surgery. So she remembers it being really uncomfortable. She was significantly bloated, had trapped gas after birth, and she was given IV antibiotics during the C-section at that time. A couple years later, she had pregnancy number 2, and she really wanted to have a VBAC, a vaginal birth after C-section. She said the VBAC went well, but the pregnancy was very difficult. She had a lot of morning sickness. The same was true for pregnancy number 3, had another VBAC, but a lot of morning sickness. And it's interesting because I asked her, were 2 and 3 female pregnancies? And she said, yes, they were both girls, which we know can be a little bit more associated with morning sickness, because when you are pregnant with a female, you have not only your own estrogen that rises during pregnancy, but also baby's estrogen. And that can pose symptoms when maybe you're not breaking down your histamines quite as well. So baby number 1 was a male, and baby number 2 and 3 and 4 were female. So she continued to have um, the morning sickness for those couple pregnancies. She started having other things arise. She had an umbilical hernia repair surgery between those pregnancies. So another abdominal surgery after having the C-section and the appendectomy already, has other abdominal surgeries. A few years after that repair, she had another pregnancy, significant morning sickness, and then listeria while pregnant. So she did get foodborne illness during this pregnancy. She was hospitalized for 3 days. It took her a while to recover, but she and baby thankfully were fine, and she went on to have a successful VBAC, another vaginal delivery. Um, so as her kids were growing, she says it was just stressful having 4 kids who she decided to homeschool. So she and her husband decided that they were going to be a homeschooling family. She had 4 small children who were very close in age. And she said at that time she was kind of just in survival, but remembers her gut always being an issue. She remembers being bloated, distended, having a lot of constipation, but also simultaneously unformed stool, lots of visceral hypersensitivity, reflux, belching, trapped gas, malabsorption. So she certainly was exhibiting lots of IBS symptoms, but she said, my kids were my priority at that time. So I just wasn't really addressing it and giving it as much attention as it needed. She kind of just changed her clothes accordingly so she didn't have the hypersensitivity, and ate foods that would make her feel less bloated, and continued focusing on her kids. Although in that time, she said, while she was raising her kids, she kept getting food poisoning. Her gut was very susceptible to opportunists, and she said she had food poisoning 10 to 12 times in the period of 10 years. So lots of foodborne illnesses. And we do know foodborne illness, if given the opportunity, can lead to post-infectious gastroenteritis. We know even once the immune system clears, the bacteria, the virus, whatever organism got into the system, they can leave behind their toxins, and those toxins can stick to the microvilli, and that can then later affect motility. So we do know up to 12% of people can develop IBS post-infectious. So she is wondering if she is one of those people, since she had it so frequently. And she said every time she would mount a stronger immune response. So her symptoms would be more and more aggressive, which tends to be the case, kind of like with allergies. Every time you're exposed, you are going to have a stronger and stronger response. So that's what she was observing. Once her kids were a little bit more independent, she said she started focusing on herself again and started looking to understand her gut. And she worked with providers who recommended things like the Viome stool test. Probably not my favorite test. It doesn't really give you any information about the microbiome, but will provide a list of foods that are supposedly ones your microbiome likes, and then tells you about other foods that your microbiome does not like. So she was given this list of foods that were a no-no for her microbiome: broccoli, cinnamon, spinach, walnuts. She had leap sensitivity testing, which we also know is not necessarily an evidence-based test, but really, from what we're understanding about things like food sensitivity tests, which is basically what leap testing is, they kind of just speak to the fact that one has a hyperpermeable gut barrier. And that is why these foods are even getting picked up in their bloodstream and showing up on these tests. So she had several foods show up there. She said they didn't help her symptoms, but they worsened her relationship with food, of course, which is usually the case. That's usually what we see, especially if you're not getting results from eliminating these foods and trying to follow the recommendations that you're given. She said she was extremely symptomatic, even with eliminating. She had worsened food fear, worsened GI symptoms. Soon enough, she developed interstitial cystitis, which is inflammation of the lining of the bladder. And we know now there are studies correlating IC with IBS. It is basically dysbiosis of the bladder, and that usually migrates from the GI tract. So her GI inflammation and GI dysbiosis was now showing up in her bladder. That is when she decided to go fully plant-based, fully vegan. And she said this did help with IC, which usually it will. A lot of the times when you're eliminating those animal proteins, you have a lot less sulfur in the diet, and that sulfur can be very irritating to nerves that are very sensitive. So it makes sense that that helped with her interstitial cystitis. A few years after that, she said they discovered they had significant black mold in their home, and they renovated their kitchen. And then the last few years, she said she had recurrent UTIs, which again plays into her interstitial cystitis and this bladder dysbiosis. She was diagnosed with several E. coli UTIs, and we know a majority of UTIs are E. coli driven. But she also had a few Klebsiella UTIs. So it wasn't just the E. coli, the Klebsiella was also prominent in her bladder, which likely means it was prominent in her gut. She had small flares even once they were treated. They recommended that she have bladder installations done. She was a bit hesitant to have this done, but eventually did. And bladder installations help to kind of calm the inflammation in the bladder and also expand the capacity of the bladder. And in that time, while she was still being treated, she also had a few hand injuries that necessitated treatment with antibiotics. So when she came our way, she was kind of still going through all of these things. She started working with pelvic floor therapy, and they had diagnosed her with significant pelvic hypertonicity. So she had very tense, tight pelvic floor muscles. And she was told also by her pelvic floor therapist that her muscles were constantly in spasm. And that was playing into not only her difficulty in fully emptying her bladder that was enabling these bacteria to overgrow, but also likely playing into her colon having dysbiosis because she wasn't completely evacuating. The therapist also said, the PT also did tell her that she had significant scar tissue and adhesions from her past abdominal surgeries. So again, the C-section, the appendectomy, and other abdominal surgeries that she had. So in the initial visit, she came to us last summer in July of 2025. She really wasn't taking many meds, just hormone replacement therapy. So she was on estradiol, progesterone, and testosterone. So she was fully supported with hormones. She was taking a few different nutraceuticals, kind of just some daily basics, some hormones like DIM, which helps with estrogen metabolism in the gut, DHEA, which helps support testosterone production, and then a few things for her just daily health, like a multivitamin, a magnesium glycinate, vitamin D3 and K2. And then she was trying things for her gut. She said she would take digestive enzymes with every meal, Beano, something called Bye Bye Bloat. And then she thought that the magnesium glycinate was also going to help with her gut. So, yeah, this is kind of what she came in with. She had recently had a stomach virus and said that her GI symptoms were much worse. And she also was having difficulty with her bladder at that time when she came for the first visit. And then she said her relationship with food felt very disordered. She was very overwhelmed, very confused. Her distension really dictated what she would eat, how much she would eat. And she said she noticed if she had bitters, like a club soda with ginger in it, that would improve her symptoms. Otherwise, nothing else really did. So she actually started with Rachel because I was not able to see her for a while. So Rachel ordered her a 3-gas SIBO breath test, and then was able to see her for the follow-up. And so when she came for that first visit, or that first follow-up with me, she came and was already on an 8-day medically supervised water fast with a physician, which was quite a shocker. So she said, I was desperate. I feel like I just needed to clear everything out of my gut. And I would notice that just the only time my gut didn't hurt was when I wasn't eating. So she felt like this was something that would maybe take care of things. And she said some symptoms were improving, but she at that time said she hadn't done the breath test. She was just kind of overwhelmed and decided to do this water fast instead. So I said, okay, well, let me know how it goes. She wanted to follow up a week later when she finished up with the water fast. The medical doctor had given her refeeding instructions. So had I. She said, because he was supervising the fast, she followed his instructions initially and her symptoms worsened immediately. She was told to juice for one day, then add in cooked foods. So she ate things like lentils, wild rice, steamed broccoli. And she said she woke up at 1 a.m. feeling like there was a rock in her stomach. She tried taking peppermint oil, since we had talked about that being a tool that will help with bloat and gas. She put a heating pad on her stomach and she said she felt a little bit better. At that time, she described her GI symptoms to be very sulfury. She said her gas smelled like rotten eggs, her stool had this rotten eggy smell. And so it was becoming evident that she had this hydrogen sulfide overabundance, this sulfate reducing bacteria overabundance. So we talked about maybe not completely eliminating sulfur foods, but just limiting them to one sulfur food per meal, and to use molybdenum. Molybdenum is a trace mineral that helps to break down sulfur. So we talked about her using the she was eating small amounts of sulfur so it could help her better digest and metabolize it. And then she really wanted to know what's going on in my bladder, what's going on in my gut. And so we talked about risks and benefits of different tests. She was curious about a stool test. And so we said that can't diagnose SIBO because it can't tell us who's in your small intestine. It can really tell us about who's in your large intestine, how your barrier is doing, how digestive juices and digestive enzymes are looking right now, and then any commensal anti-inflammatory species that might be missing from your gut. So she decided that she wanted to move forward with that, and then we would circle back to a SIBO test if that didn't completely give us answers. And so again, this is a very familiar story. Every patient has their own unique testimony, if you will, with their gut, but they all usually come in with quite a bit that has happened. You do have, like I mentioned, that rare person who says, I was fine until this one thing. And then since that one day, everything's been different. But most IBS patients, we know they have specific risk factors. We know IBS is more predominant in females. So this patient definitely fits that. One study found that over 76% of those with IBS had at least one ACE, which is an adverse childhood event. This patient certainly did. So she very much fits in the demographic of IBS. And then when you're kind of typing her, she seems like she has IBS-M. So she's kind of mixed diarrhea, constipation. She certainly experiences bloat very frequently and meets all that diagnostic criteria. So her team had diagnosed her with, but she said, okay, well, again, the question on everybody's mind, the $1 million question is, why are my bowels irritated? So for her, it was kind of understanding her story. So that way we can understand the roots of her IBS, of genetic factors, environmental factors, nervous system factors. We talked about changes in her motility based not only on neurotransmitters, but foods she was eating and scar tissue and adhesions. So for this patient, we really kind of took her through her story and really helped her understand how that meant gut, bladder, gut, gut hormone connection, gut bone connection, all these things that she was experiencing that seemed inconsistent or, unconnected, but really for her were connected. And so for her, we're understanding, okay, is it just that you have dysbiosis and the microbes themselves and the microbiota are off and, there's a little bit of a change in that? Or is there a little bit more? Is it kind of the collective genome of those organisms and their environment and the rest that's involved with that? So we're understanding something's off with the microbiome. And so to help really understand a little bit more about IBS, which now is called the DGBI, a disorder of the gut-brain interaction, use the Rome criteria. And we know the Rome criteria is based on 33 adult and 20 pediatric disorders of the gut-brain interaction. But really, a lot of them are kind of consolidated and condensed into something disturbing motility, something affecting the nerves, causing nerves to become hypersensitive, alterations in the mucosa, the protective mucosal barrier, something off with the microbes and their environment, and then alterations in that central nervous system, because we know that directly connects to the gut enteric nervous system. So we here at Married to Health, as you all know, took that and applied it to what we call the 5 M's. We try to simplify for our patients to understand a little bit more. This makes it easier for us to help our patients understand as well with the help of their care team. But really, we want everyone to understand, what are your 5 M's? Which of your M's seem off or have we investigated are off, right? What testing have you done? What symptoms do you have that have kind of told us one of the M's is off with either, again, the microbes or the microbiota as a whole, your movement or motility, the membranes that are kind of housing this microbiota, your mind, that central nervous system, that gut enteric nervous system, and metabolic organs that are very key, very vital to supporting somebody as a whole. So for this patient, we kind of broke it down and we said, okay, these are the 5 M's, and this is what makes us believe something is off with your various 5 M's. So, with her microbes, she said she had chronic childhood strep that led to that tonsillectomy when she was in her teens. She had a severe listeria infection in one of her pregnancies. She has E. coli, Klebsiella, sorry, I wrote E. coli, Klebsiella, mold exposure, excessive antibiotic use. So several hits to her microbiota as a whole. With her motility, we see she has significant pelvic floor hypertonicity she's been diagnosed with. She's had several abdominal surgeries with residual scar tissue and adhesions. And then her central nervous system would also play into her motility. So that's going to factor in. With her membranes, we can assume she's had positive response from LEAP testing and this Viome test. So again, LEAP testing tests IgG in the blood. Food should never see your IgG immune system in your blood. So if things are showing up on LEAP testing, food sensitivity testing, we can infer you have a hyperpermeable gut barrier. So not only did she have that, she had regular mucus in her stool. She has visceral hypersensitivity that she's had for decades. So we can say not only is likely the skin barrier, the gut epithelia, a little bit more hyperpermeable than it should be, the mucous membrane itself is also likely worn down and deteriorated where her nerves are hypersensitive. As far as her mind goes, we know she's had several ACEs, those adverse childhood events. She's had a lot of maternal stress, a lot of other life stress. So that has affected her central nervous system and how her nervous system feels as a whole. Metabolic organs, she does have, which we will see at that time, we didn't know that there was anything going on, but we will see that there was some involvement there. So we got the results back from her stool test. We decided to do a gut zoomer. And we know the gut zoomer provides about 240 pieces of data. These are not yet validated, so we can't necessarily say that this is definitively everything that's going on, but they can give us some interesting clues that we can then verify through other evidence-based testing. But on the gut zoomer, it's giving us not only kind of the balance in the commensals, which are helpful anti-inflammatory microbes, and the opportunists, which can generate some inflammation. It's also pointing out different microbes that are involved in either things that will help or things that can potentially harm the gut. And so it says here different species that were prevalent in her gut, some that really stood out to us because she had them in very strong abundance. And, the report is about 30 pages. So I just included the 3 most interesting pages that were the most, the best summary that we had. She had high amounts of Proteus mirabilis. We do know that this is a sulfate reducer. We know that this is one of the most common species that's involved in the inflammatory bowel disease microbiome. And we do see that this is a predominant species in colon cancers. We know both of those conditions are heavily fueled by these sulfate reducing bacteria. So she had very high amounts of Proteus. In fact, she was kind of off the charts with it, with the way that this test measures things. She also had amounts of fusobacteria and low amounts of some of the others that keep some of these sulfate reducers in check. So she had very low F. presnitzii, which we know is a main commensal and a main anti-inflammatory. She has low levels of several Bifidobacteria strains. And then that has enabled the overgrowth of some other opportunists. And she did a little bit of staph in her system as well. So those were the main players that we saw that were involved in her gut. And then we see here that her immune system was beginning to become involved. So again, something else that kind of confirms for us that her membrane or her mucus is kind of off, because she did have elevated levels of lactoferrin. So the ones that are highlighted here in red are highlighted because these were described or demonstrated to be elevated. We know lactoferrin is almost a fire extinguisher of the gut. So lactoferrin is something that the GI system or the immune system as a whole will employ in cases of prolonged inflammation. So her body was trying to kind of put out these fires by deploying some lactoferrin to the site. Also, her beta defensin 2 was elevated, and this is part of some of our immune cells that will activate when the immune system is becoming involved. So her intestinal hyperpermeability was provoking these different types of immune cells to deploy their defenses and really try to help combat some of this inflammation that was present there. So we went over together her tests and kind of described to her, okay, these are your helpful commensals that we need to work on. These are some of the opportunists that we saw were overgrown that we will need to try to keep in check without over killing and over attacking, because you heard she has this history of high antibiotic use. So we didn't want to continue to just bomb and kill. We really needed to be very targeted in how we were going to approach this. She also came back with elevated anti-gliadin and anti-Saccharomyces cerevisiae antibodies. These were actually much higher than the anti-gliadin antibody. I advised her to really just focus on yeast, which and we asked her, just take notes. And that's what usually we'll ask people. We'll say, just take notes on these for a few weeks and see if you're actually responding to these things or not. And she did notice every time she ate yeast in particular, not necessarily just wheat, but if it was something very bubbly and yummy, like a bagel, a focaccia, a piece of pizza, any other bread or cracker, or anything else made with baker's yeast, nutritional yeast, she would have extreme bloat and distension. So her immune system was beginning to react to these things. So we asked her to avoid the yeast. And then she started noticing that gluten-containing foods were really exacerbating her constipation. So we asked her to take a break from those for 8 weeks. She said not only was she seeing undigested food in her stool, but the test picked up on that. So when she sent in her stool sample, they did say found undigested fiber in her stool, and she had much lower pancreatic enzymes than would be optimal to help her break down and digest her food. So that's another facet of the barrier. If the barrier is degraded and broken down, the pancreas is asked to really upregulate its function, kind of like with diabetes, right? When we inundate the cells with glucose, then the pancreas and the beta cells really need to increase their function, but can only do so for so long. And after that, they'll need a little bit of support to make the supplemental insulin. So the same can happen with digestive enzymes. The pancreas will try to pick up the slack. It can only do so for so long. And after some time, it will need some supplemental support until everything is able to repair and calm down. So that was the case with her. And then again, we saw there was evidence of an intestinal hyperpermeability there with elevated zonulin protein, which zonulin is a protein that is predominant in the gut epithelia, the gut skin itself. She had very low secretory IgA. That is the immune system that is found in the protective mucosa. So her secretory IgA was very low, and these usually will indicate intestinal permeability. And it's hard because we don't have any evidence-based test that can help us confirm or deny that for patients. So we use our best clues that we have and always this is not evidence-based, but this is the best that we have to work with right now. So we can kind of try to make suggestions based off of this. So again, we are identifying, she's been diagnosed with IBS-M, but what microbes were involved in her IBS? It's evident based both on the tests that we were seeing and her symptoms. She had some ESO, that intestinal sulfide overproduction. We see as well that she had some of those microbes that produce hydrogen gas and are involved in that just small intestinal bacterial overgrowth, that hydrogen overgrowth. She really didn't have a lot of methanogenic overgrowth, which she thought she would because she was so constipated. But again, this helped us understand that's coming from elsewhere. That's more neuromuscular and not necessarily microbial that's causing the constipation she was experiencing. She didn't have any of the indicators or markers for any inflammatory bowel disease. So even though some of those microbes were present, she didn't have elevated calprotectin, and that was nothing her team has ever found either. So there was nothing to say this is more concerning in inflammatory bowel disease. So we know that when we're investigating these things, again, we're identifying with the 5 M's what is even causing these different 5 M's. And for each patient, we're really saying, okay, what check marks are we checking off? So we kind of saw with the patient what affected her microbes. We were identifying, is there anything going on that indicates that there could be some biofilm? That is also very microbially driven. One thing that I think I skipped over was the fact that she had elevated ruminococcus. And ruminococcus was shown in a really amazing 2023 study to be the most prominent microbe that creates biofilm. This saccharide protective casing that is found usually in the end of the small intestine, in the ileum, and in the beginning of the colon, in the ascending colon. They're usually finding it around that ileocecal valve. A study showed that over 85% of cases with biofilm, where it was visible on camera and they also biopsied it, they had ruminococcus, especially ruminococcus ganabis present. So this patient did have ruminococcus present, just at least. And we see that these are different gut disorders associated with these microbe biofilm. So this patient, again, we don't have any type of confirmation from it, but we are wondering if there is any biofilm present for the patient. It's been an ongoing conversation we've been having with her getting a colonoscopy. She's a bit hesitant to have a colonoscopy and she's never had one, but we did have the conversation of the criteria. It is recommended once you turn 45 to have a colonoscopy, especially if you have some of these risk factors. So it's an ongoing conversation. I'm going to keep advocating that she have a colonoscopy. And for her, again, she prefers more integrative holistic medicine, but I'm trying to encourage her to say, hey, this can help us in our integrative and help the rest of your team, rather with the more integrative investigation. I'm curious to see if we see any visible biofilm. And then again, if you get a care team who's knowledgeable about biofilm, they can actually go kind of jet wash the biofilm off. So if you all want to see this process, it is in my presentation, but it's pretty cool that a gastro who's trained in this can almost take what looks like a power washer and wash off the biofilm. And it's amazing. You then see, after they've washed it off, you remove this red orange goop that is that lipopolysaccharide that's made out of fats and carbohydrates and other trace minerals, and you can see this beautiful pink tissue and visualize the microvilli. So cool when they're able to go in there and remove it. It's a nice silver bullet to get rid of biofilm and a lot of the microbial colonies that live under the biofilm, because again, usually they're opportunists who are living in there. So I am encouraging the patient to have a colonoscopy for this reason, that, hey, you can get a nice internal jet wash if you need it, if your care team is and trained to do that. And we know that that can help improve and enhance her movement, her motility. She is continuing to work in pelvic floor physical therapy. Throughout our time, we'll talk about how we have talked about ways to support scar tissue and adhesion. I recommended she ask her physical therapist about different tools she can use between sessions, like scraping tools or cupping tools that can help kind of decompress the scar tissue and the adhesions so that there's better movement of the nerves and the muscles. And we're also working on her nervous system. For her, we've check. Yes, microbes. Yes, motility. Yes, the membranes. There's indicators that the membranes are broken down. This is affecting pancreatic enzyme production, absorption of nutrients. And as we continued to work together, we also was exhibiting histamine intolerance, which can happen with a hyperpermeable gut, since we know we make the enzymes, that the predominant enzymes, DAO, that breaks down histamine in the gut barrier. So over 60% of our DAO, our diamine oxidase, is produced in the small intestinal lining. And if it's hyperpermeable, that action can't always be carried out. So she didn't think she had allergies because she doesn't tend to have significant seasonal allergies. But when we went through some of these symptoms, she was having headaches and some occasional dizziness and brain fog. She said her menstrual cycles were historically very painful and uncomfortable, which have kind of reduced over the years. She would at times have tachycardia and this rapid heart rate, especially after exercise or some type of post-exertional tachycardia. She would even have post-exertional fatigue, where she said, I will feel wiped out after working out for a couple days. And then, of course, she has the GI involvement. So not everybody has the respiratory symptoms, but we might be exhibiting histamine symptoms elsewhere. And she did also get tested with her team. And again, with the mind, we know not only will these neurotransmitters impact things, and we make a large percentage of our neurotransmitters in our gut, we still aren't sure, though, the percentage that move through the gut-brain barrier. So we're unsure that of the percentage of this 90 to 90% of our serotonin that's produced in the gut that actually goes into the central nervous system through that blood-brain barrier. But we know that a lot of it is made in the gut. So not only is it the nerves themselves and the vagus nerve that starts in the brain and moves throughout the entire body that can impact our gut motility, it's also these neurochemicals and these neurotransmitters that can also impact things. We know serotonin is widely involved in our GI motility. So if serotonin production is decreased, we know that GI motility might also be decreased at the same time. So this patient, we really put a strong focus on supporting that gut-brain connection, supporting the central nervous system to support the gut enteric nervous system as well. And then once we found out that there was something that needed support metabolically, we were really trying to optimize her glucose management to really spare her pancreas and the beta cell function. And also, we were trying to support pancreatic enzyme production. So we were trying to reduce some of that burden. She was already on digestive enzymes herself, but we tailored them a bit to better fit this patient. So, this patient, we can't confirm or deny, like I mentioned, if she has SIBO, but I am assuming she likely does just based on the fact that her bloat, her distension, they're very localized in the middle of her abdomen. She has a lot of belching. She has reflux. So she has a lot of the SIBO symptoms. So we will see in due time if we are going to SIBO test her to kind of confirm or deny this. And she and I really spoke a lot about how the elimination diets weren't helping her. If they were, she's been on them for quite some time, and how for her in particular, with her very low secretory IgA and her elevated zonulin, these elimination diets or water fasts were really not in her best interest. So we really talked about how she needed to refeed, not starve it further, and the dangers for her specifically on water fasting and elimination diets. So that's been an ongoing conversation as well of refeeding her, to refeed her gut in a way that won't cause symptoms. So we really took all the 5 M's and have created a plan that would really work for her, because again, she was coming in saying, I'm listening to the Dr. Gregors and the Dr. Barnards, and I'm reading the books and I'm listening to podcasts, and I don't know why I can't eat the fermented foods and I can't eat the 30 plus plants. More than familiar with all of these different studies and all of these different recommendations playing into her body dysmorphia and her disordered eating, because she was trying to do those things, but there was something off. So once we tested, we got a little bit more information, and then we created a plan for her and what we were going to do for her. For her in particular, we really started with targeted therapies that would help some of the most insidious microbes, if you will, that she had present. And for her, this was the sulfate bacteria. So we started targeted herbs that would help reduce the populations of these sulfate reducing bacteria, because we know they not only produce that really foul smelling gas that she said really sometimes prevented her from going to exercise classes or felt very uncomfortable when she was in public, they also irritate the nerves. So that will irritate those gut enteric nerves, and studies show that that can irritate the central nervous system as well as just being highly inflammatory to the gut and the surrounding organs. So we decided that that was going to be a starting point for us to work on these sulfate reducing bacteria. We incorporated biofilm disruptors along with her herbs, because there was evidence that there likely was some biofilm there with resistance and reoccurrence that she had with other infections. And then we decided on how to really work on motility to continue in pelvic floor physical therapy. We got her started on eating her 2 kiwis a day. She was eating dragon fruit and chia seeds and foods that were highly soluble in fiber to really just hydrate the stool and make it easier for these very tense pelvic floor muscles to pass a slightly softer stool. She started taking a soluble fiber powder as well in order to really enhance that effect. And she started taking the right type of magnesium. If you recall, I mentioned that she was taking magnesium in the beginning when she came to us, but it wasn't the correct form for the gut. She was taking magnesium glycinate, and studies show that that is not very well absorbed into the gut and it doesn't function very well in the gut. Magnesium glycinate is fantastic for headaches, peripheral discomforts, restless leg, body aches. But really, if you're using magnesium for the gut, you want to go more for magnesium oxide or magnesium citrate. So she started on a blend of those in lieu of the magnesium glycinate. We also had her stop several of the supplements that she was taking outside of the hormone supporting supplements because they were either triggering histamine response that she didn't realize, or again, just weren't tailored to her enough, maybe weren't enough of a therapeutic dose with the digestive enzymes, weren't enough to support some of these things that she had going on. We did also start incorporating some motility support with things like dietary peppermint, dietary ginger as often as she could consume it. She had kind of emergency peppermint capsules and emergency ginger capsules to use in times where she had significant upper GI bloat. She would use the ginger, or lower GI bloat, she would use the peppermint as she was traveling or going out to eat or just day to day as she needed. Once we continued to work on her microbiome, we started in due time incorporating some membrane tools. This was just in the last few months that we've incorporated some of the amino acids that are very predominant and prevalent in the gut epithelia, in that connective tissue. So she started taking something that has L-glutamine and acetylglucosamine and some of those mucilage agents, like aloe, marshmallow root, DGL, in a blend that has decreased her visceral hypersensitivity. And in fact, she said that those tools also helped completely reduce her bloat feeling. So she no longer felt bloated. She certainly no longer has that visceral hypersensitivity where her bloat is dictating what she can comfortably wear. She's back to wearing anything that she'd like, and she's not feeling the pain of that bloat and that nerve hypersensitivity. As far as her mind goes, we recommended that she use Nerva. So she did complete the 6-week Nerva program, which is a great evidence-based gut-brain therapy. It's gut-directed gut-directed hypnosis. And she said this was fantastic. She would do it every night before bed. It would range anywhere from 15 to 20 minutes, but she said she really noticed a huge difference when she went through the Nerva program. So she really liked that. That made a significant difference for also that visceral hypersensitivity and her relationship with food. Not only was it a decrease in her symptoms that helped with her relationship with food and have less food-driven anxiety, but she said Nerva really helped with that as well. It decreased her food anxiety and her bathroom anxiety as well. So that was helpful for her. As far as her metabolic organs go, we recommended that she try to incorporate as many bitter foods as possible. Her tolerance of these has increased tremendously over the past several months. As you recall, initially, if she would eat things higher in sulfur like wild rice, lentils, broccoli, she would have excruciating pain that would wake her up in the middle of the night. She is able to eat a lot of these bitter foods now. She's eating broccoli sprouts and she's eating other cruciferous vegetables like asparagus and Brussels sprouts. She says she can go out to eat and it's no longer an issue. She's eating allium vegetables as well. She's able to eat onion, garlic, shallots, and she's not having any issues with having some of this support. So we are able to incorporate the bitters that we know the liver and gallbladder really enjoy. She's able to incorporate a wider variety of antioxidant-rich food just to continue to support the liver and the gallbladder, since we know they're helping create bile, which helps to be a natural controller of these sulfate reducers. She never really had any markers that would tell us otherwise that there was anything going on with the liver and gallbladder, but we knew we needed just extra TLC, and who doesn't need extra antioxidants? So she's able to tolerate those. We got her on pancreatic strength enzymes, digestive enzymes, instead of just over-the-counter digestive enzymes. She's on pancreatic enzyme blends, which tend to be about 20% stronger than just an over-the-counter digestive enzyme. So she's on a little bit of a stronger support. We have started incorporating more protein into her meals for better glucose control, really ensured that she's properly hydrated to support her kidneys, and are just continuing to just optimize her lifestyle to support her metabolic organs. The MNT that we mainly had her focus on, I was very conscious of this, especially knowing she had history of eating disorder and was having disordered eating when coming to us. I didn't want to put her on severely restricted diets. So I, again, Didn't even put her on a fully low sulfur diet. I just recommended she limit sulfur to one high sulfur food per meal, and gave her the tools that would help her break down the sulfur instead, like the molybdenum. And she also was given the DAO enzyme so that she wasn't going on a low histamine diet. She just had the enzyme that would help her better tolerate histamines. The diet she came in that initial follow-up with was almost like an elemental diet, that water. Again, this is where knowledge and wisdom come together, because we can just use the knowledge that's in the data to say the elemental diet works. We see high success rates with the elemental diet, 83% success rate in eradicating SIBO overall. Fantastic. But again, you need the wisdom to understand when to apply that to whose microbiome. If it's an already starved microbiome, if this microbiome has been hit a lot with antibiotics and other things that would significantly affect it, that might not be the time to choose an elemental diet. So even though she never really officially was on an elemental diet, it was kind of like that. The goal of the elemental diet is also to starve things out. And that's what water fast. That's what this physician's goal was in putting her on a water fast. He said, okay, let's just starve these bugs out. Wasn't necessarily the approach that she needed, which is why she felt somewhat better for a few days and then felt much worse. So we know we're reading her microbiome now that we have a better balance and she's back into eubosis, just subjectively, we now are able to refeed commensal anti-inflammatory set of microbes that she has with the right prebiotic fiber. Like I mentioned, eating a wide variety of prebiotic fiber. She's eating fermented foods again and tolerating them fancy, and she's feeling great. So, I really feel like the recommendations and the order that we went in was going to be really important. Recommending to her that maybe, again, she's avoiding these water fasts and these highly restrictive diets in the future is going to be important for her specific microbiome. Tailoring the recommendations for her helped us really see great results. So her low sulfur MNT for 4 weeks plus the DAO, the histamine degrading enzyme, reported 98% resolution of these hydrogen sulfide symptoms in 3 months. And those have nearly 100% disappear. The histamine support, she reported 100% histamine reduction in 6 months. Now it's spring. She's fine. She's not having any of those histamine symptoms at all. She's experienced a 95% resolution of slow motility with the motility support that we have her on. She says she's experienced a 65% reduction in her stress and anxiety levels on the Nerva program, and just since continuing to support her central nervous system and her nervous system as a whole. She has reported a 95% reduction in visceral hypersensitivity just in the first 3 months that we had incorporated some of these different things. And then we kind of talked about her continuing pelvic floor therapy because she had stopped for several months in the middle of it. But we talked about the importance of continuing that. We also have continued some of the supports that she's on. And this was a message that the patient has sent. She said, not exaggerating, this is truly the best I've ever felt in my entire life. I'm very hopeful. I can never thank you enough for all your help after all these years of suffering. So our plan from here, now that she's, again, for the most part, feeling really, really well, she wants to repeat the stool test. I don't necessarily feel it is necessary to do so. Just we're subjectively going with the information that we are feeling better. I don't feel the need for her to invest in another one, but she would like to. So we're going to give her that objective information to see the shift in the microbiome objectively on paper. I am continuing to encourage that colonoscopy again, just because of the microbes she had, her GI history. And then something I wrote down is in the future, we might possibly do some post-infectious gastroenteritis testing. And that usually requires just a really small sample of blood. It's an at-home test that the patient can do. And this helps us see if the patient has antibodies still to some of those toxins that are released by these foodborne illnesses. So that way we really understand what does the future look as far as her motility support. Sometimes when patients do have these antibodies present and we don't know, and we just take them off of the motility support, they might have relapse of symptoms. So to me, I think that would be interesting and valuable information to assess in the future, but that's our plan for now.
Okay, this program is not for you if you're looking for a quick fix and you're not willing to put in the work. We have spent years and years creating a program that actually helps you get to the root of gut dysbiosis like SIBO and IBS, but it is not for you if you're looking to get better in just 1 week and something very, very quick. We have made it simple, affordable, and go at your own pace, but you still will be the one putting in the work to get better and truly overcome your SIBO and IBS. Take advantage of the current sale price for the Good Gut SIBO IBS program because it will be ending soon.
So again, we took our approach of the 5 M's with her. We really customized the approach and kind of just didn't shoot in the dark, or didn't just say, hey, let's just have you not eat and that's going to really help your gut. A customized approach is always key when working with GI patients. We need to test, not guess. We definitely need to address food and non-food issues as dietitians. Have the goal always to add more plants, not fewer, and then really have that long-term etiology focused care. So it's not just a temporary improvement of symptoms, but it's just long-term within the gut. So patients truly are able to get to that heal with each meal. All right. Thank you so much. Any questions? And all my sources are there.
I just wanted to say thank you for sharing the journey. I think it's so important to know how you're taking someone, especially from a case of a lot of fear with food and with so much pain and unable to tolerate foods at all. And so it's pretty hopeful for people out there to understand that the body is so resilient and will always be wired for healing if given the correct support and environment. So it's kind of cool to see that even when it's, it feels like it will never heal, or that's it, that's your destiny for the rest of your life. Like, no, please understand that your body will heal if given the right support. And this was like a journey kind of like that, where there was a lot going on, but with time and the right tools and step by step breaking everything down, the body was able to find some safety and stability, and then start to tolerate the foods that it's intended to tolerate. So
thank you.
Just when I was listening to these, I was just thinking, wow, Dahlia, like, that's so cool. What a gift that you're able to help patients that have such complicated cases.
Thank you. I appreciate it. I'm always grateful. I'm always grateful because it's not necessarily the traditional path. And so it's just being honest and open and very inquisitive with patients. But her body wanted to heal, and she was very resolute in healing as well and put in such tremendous work. So she's done an amazing job.
Another thing I was going to say, more of a comment as well, that I think a lot of patients don't necessarily come in thinking about is, like, even within these strategies and recommendations that we have as dietitians, there's always room for personalization. Like, for example, with the sulfur support and the, with the histamine support, it's, yes, we can eliminate these foods that are in these categories. However, we also have other strategies that still address the same issues with a different way of going about it, or with a different tool, just so that based on disordered eating behaviors or other, whatnot for those specific individuals, that it's like we have tools, and then within those tools, we have more tools that we can really figure out how to go about this in the best way for that patient. And I think this is just a really great testament to how you can do that, even with a very complex case. We can still really personalize this for you based on your unique situation. So it's really great emphasis on that.
Mm-hmm. Absolutely.
I was curious on, like, the biofilms, and because the patient is hesitant to do the colonoscopy, what other approaches might you have, and if there are any on targeting rhamnosis in particular, outside of just like using biofilm disruptors on their own?
Yeah. So interestingly, the Zoomer now offers, they check for a marker of lipopolysaccharide antibodies. So that's one more marker that can possibly indicate some biofilm. Other than that, or again, the colonoscopy would be the gold standard. So colonoscopy would really visually show you that. And again, if the gastro is trained, they can also sample for that and culture for that, and then even culture for the bacteria that are responsible for that. But we do know that is rare and few and far between. I've never found a provider who offers that. But you can at least look at the colonoscopy together with the patient and kind of see that. So in my thought process, especially if a patient comes to us with resistant SIBO or they've had this recurrent dysbiosis, I'm going to incorporate the biofilm disruptor. The benefits, I think, outweigh the risks, unless, again, the patient's allergic to one of the enzymes that's in the biofilm disruptors, because the biofilm disruptors that we usually are utilizing are a blend of different enzymes. They are a blend of things like monolaurin and ginger, so things that really help kind of support that immune function. So again, unless there's a contraindication there, the benefits of utilizing one and employing one, I think, outweigh the risks so that the patient doesn't see relapse and we can find a complete clearance of the dysbiosis. So that's kind of my thought process. For this patient, it seemed appropriate, but I think with most of our patients, we are incorporating that use of the biofilm disruptor along with, even if they're taking antibiotics. I have many patients who come to me and they're prescribed antibiotics for from their gastroenterologist or their gastroenterologist or their primary provider, and I still recommend that they take a biofilm disruptor with it in order to just enhance the effects. I have a patient right now who was just diagnosed with H. pylori. She was given that triple antibiotic therapy to treat H. pylori, and I still made that recommendation to her. Let's use a biofilm disruptor and let's incorporate that just so we can get the most bang for your buck and the most bang for your efforts. But yeah, hopefully that answers that.
Thank you. And with the biofilm too, because I think that there's like some concern for some of those mucilage like foods or ingredients, like if there is concern for biofilm, do you have any like experience with that, or have you not found that to be an issue at all?
Of which ones particularly?
I think kind of like slippery elm and like marshmallow root. I think I remember that from like, yeah, if like it potentially will worsen if there is already biofilms present, but it seems like with this patient that really helped with that permeability regardless.
And so yes, because again, they're using the lipids and the polysaccharides in order to incorporate it. That is where, again, we're using that best judgment in order to say, okay, let's try to clear most of the dysbiosis up front. Usually we are incorporating that membrane support several months into the protocol. And the analogy that I give to the patients as to why, because sometimes I have patients, of course, we have really bright patients, and they're like, well, why aren't we using L-glutamine from the beginning? Why aren't you putting me on aloe? The analogy that I give is that's kind of like us going to pick out wallpaper when your house is still on fire. Let's kind of quench the fire before we're thinking about redecorating. So in due time, we try to incorporate some of these recommendations when it becomes evident to us. Both we use objective information testing and subjectively what the patient's telling us to make those decisions of when we're going to incorporate some of these other agents. So it's definitely not something I would recommend incorporating from the very beginning unless there's indication to do so. And you know what? We have done that in certain cases of inflammatory bowel disease. But again, it's assessing benefits and risks with that.
Thank you. And I was one more question about like the elemental diet. I'm just curious if you've yet had any patients that you recommended like an elemental diet to, and what patient did you find like that was a good fit for?
Usually this is going to be the methane patient. So it's very rare. I probably use it in under 5 patients a year, but I do sometimes incorporate it with my methane dominant patients because we do see the strong efficacy for it. But these are usually patients who have very strong underlying etiologies for their dysmotility rather. So one of my patients who has just persistent methane overgrowth and intestinal methanogenic overabundance. She has gastroparesis. And now we're investigating if she has a connective tissue disorder. So is it both connective tissue involvement that's impairing her motility and the gastroparesis? That we've put in lots of efforts in order to support those. She's just been put on a new prescriptive motility agent that's been very helpful with the gastroparesis, and that's helping decrease her methane levels. But for her, she just needed a little bit of a break and a little bit of respite from her motility issues. She was so bloated. She was so distended. She was so uncomfortable all the time. We knew why. There was just, all of our best efforts weren't getting her there to complete clearance. So for her, we said, let's do an elemental. And she did it for 2 weeks. Her methane and hydrogen went to 0 in those 2 weeks that she was on, those 14 days that she was on the elemental diet. They're usually in the 60s and 70s. So she had a great response to it. We knew, I informed her going in, I said, it probably will not last forever. And she said, that's okay. I'm so uncomfortable all the time. Even if it only lasts for a few months, I'm okay with it. So that was a patient I used the elemental diet with. Another one of my just persistent dysmotility patients I've used it with as well. And she said the same. I actually think I had a 14-day sample that I sent to her. So she didn't need to financially invest in it. It was just more of the mental, emotional, physical investment of going through 14 days of only drinking this elemental formula. But I did send that to her, and she did the 14 days, again, knowing that, hey, this probably isn't going to resolve your IMO, because we do know you have mast cell disease, you have a connective tissue disorder, and she's under a tremendous amount of nervous system stress, and that was affecting her motility. And again, that's something that's out of our hands. So she knew this probably won't last forever, but this is a helpful tool for now. So that could be the case in which you're using it.
Thank you.
Okay. Any other questions or inputs?
What do you feel like was the biggest challenge or difficulty with this patient that you guys had to overcome, either together or just within being a practitioner, seeing this patient, this type of patient, or this type of GI issue?
Yes, that's a great question. So I will say this patient has been a really great patient to work with. So she and I haven't necessarily hit kinks in the road. With other patients, definitely finances can pose difficulties, because every single one of these interventions requires a financial investment. The food, the testing, the nutraceuticals, the doctor's visits. So financially, I think we can hit snags. I often will have patients doing so well, and then they get foodborne illness or they get gastroenteritis. That happens so often. They're like, my kid came home with norovirus and I got it, and then I feel like I'm relapsed. And of course, it's never a 100% relapse, but that often we'll see, or they'll get some type of strong virus, flu B or COVID, and they feel like that really throws off their microbiome after they were doing well for a really long time. Or, kind of like we were talking about before, things that are just out of our hands, ongoing trauma, ongoing life circumstances, ongoing things that there's no supplement for that, right? There's no food that we can eat to, improve your financial situation or decrease your family stress. So those are some of the barriers that we tend to see with patients. With this patient, she also just, I think for many reasons, has just a positive, different perspective on life. She has had snags in the road. Her, mother-in-law has been in and out of the hospital as of late, and they're her primary caregivers. And she's like, it's fine. It is what it is. She's fallen several times and injured herself. And she was like, oh yeah, but it's fine. Everything's great. So I do really think that the perspective and mindset that one brings into the situation also can play in. And again, your life circumstances can often dictate the perspective that you're able to even maintain. But this patient I'm amazed by it. And I always tell her that. I'm like, I don't know how you're still so joyful throughout all this happening. But she's kind of like, it's fine. She has very strong faith, and she has very strong support. So she has a great relationship with her husband and her kids and her faith, and she has really great outlets. So she is relatively unfazed when some of these challenges come in. So I think if they do affect her, they don't affect her for as long as somebody who might not have those opportunities and who might not have the same support and really might be impacted more on a nervous system level by some of these things. So I think, this patient in particular has been not as challenging, but we definitely see them with other patients who might have the exact same test as her, but just, again, different nervous system, different life circumstances. All right. Thank you all so much for spending this time. I appreciate us all getting to share our successes and struggles and patients who can seem very complex, but I'm just so grateful and just feel so fortunate to be able to support people on this journey, and that we all have the education and resources and ability in order to support them. So thank you. Thank you. It's just been an honor to work with this patient in particular and all of our patients, as well as we just help them on that journey to heal with each meal and feel with each meal. That is our goal. Well, we'll talk to you all very soon. Thank you.